Okay, good morning, everyone, and welcome to HARC number 8 oral abstract session. I'm Kathy Mead from the Moffitt Cancer Center, and I hope you've been enjoying the conference. We have another good half a day left. In this particular session, we're hoping to have 4 presentations to share with you today, and they cover 4 highly relevant topics related to health literacy, including critical health literacy, the assessment of online Medicaid enrollment materials, COVID-19 misinformation, whether it's fake news or information being distributed through social media, and then to round us out, the use of digital visual-based tools to reach disparate populations. So I warmly welcome all of you to this session, and to assist in facilitating and hosting it are 2 members from our Health Disparities Lab here at the Moffitt Cancer Center, Carol and Samantha, who will introduce themselves, kind of give you the lay of the land, give you some pointers on the timing of how this will actually unfold. So Carol and Samantha, take it away.
Good morning, everyone. So my name is Carol. I work with Moffitt Cancer Center, and so does Samantha. We will be helping moderate with this session. Just to let the presenters know, you will have your allotted time to give your presentations, and then we will, if there is time, we will go ahead and go on to some questions. Samantha will be moderating chat for the presenters, and I will be timekeeping just to kind of assist you all.
Yeah, I really encourage everyone to put your questions in the chat. That way we can have a really nice discussion today. Thank you.
All right, and our first presenter will be Dr. Lorraine Wallens. She is an associate professor at the College of Medicine at the Ohio State University and a Fulbright Scholar in the Republic of Moldova in 2009 to 2010. She will be presenting today. And Lorraine, you can go ahead and get started.
Hi, good morning. Thanks so much. So my presentation is entitled Assessment of Internet-Based Medicaid Enrollment Materials and Resources. I'd like to acknowledge my 2 co-authors, Varsha Prabhu and Brian Ahn. Both of these students work with me on this project as undergraduates at Ohio State as part of a course-based undergraduate research experience. So just some background. So just approximately 72 million Americans, or 1 in 5 individuals in the United States, receive Medicaid benefits. A plethora of research over the past several decades has documented that many of the steps that we require individuals to apply for Medicaid often are barriers to actually enrolling in the program, such as not understanding the eligibility requirements, lack of required documentation, difficulty obtaining information, and then also, as we're going to see, completing the materials. So what prompted our interest in conducting this study? So about 10 years ago, I worked with various health literacy researchers where we looked at enrollment forms for adults in English, Spanish language as well, and then also for the Children's Health Insurance Program, or CHIP. A more recent study also was done at reading level of renewal applications. So overall, these studies found that these materials are exceedingly difficult, and we wanted to see had anything shifted over a 10-year period. So in February of this year, we conducted a comprehensive health literacy related and content assessment of state government internet-based enrollment resources, materials and resources. So we used several established tools, including the PMOS iHersh, and then also the user friendly tool that was developed by Dr. Terry Davis and colleagues at Louisiana State University Shreveport. So we all reviewed these materials for document complexity, layout of English language paper Medicaid applications. We also reviewed government platforms, looking at was an online enrollment option available, toll-free telephone assistance, and live chat function. So our previous studies that were done approximately 10 years ago we found that the materials, the applications that were available on state websites at that time were uploaded PDF documents. So we were very interested to see, has the application process evolved as technology has as well? So what we found was that 40 applications, English language paper applications in PDF format were available on these government platforms. So again, we had all 50 states in addition to the District of Columbia. We found that of those, 28 had a Spanish language Medicaid enrollment application. Okay, so just over half. And then 4 government applications offered kind of an array of other languages, with the most common being Mandarin, Russian, or Vietnamese. So by and large, that options for language availability was limited to English and to Spanish. So as we can see here, we compared and contrasted the data from 2008 to 2021. Okay, so we saw that there were all states, there was, with the exception of Kentucky in 2008, all states in the District of Columbia had an online kind of paper equivalent available on their website. 2021, we found 40. By and large, there was some improvement related to some layout features, but by and large, there are some things such as, white space, formatting, that really still needed much work to actually make these readable for those that are attempting to apply and secure Medicaid enrollment. Other things that we found, that overall the document complexity was relatively high. Okay, this is part and parcel due to the amount of documentation that's needed to apply for Medicaid, which is, often very complex. Other things, an online Medicaid enrollment option was nearly universal, which we found was a positive. So they also that by and large, 34 of the 51 that those reviewed offered a telephone assistant. About 20% had a live chat function where a potential enrollee could ask questions related to their application. Other things, so that only 7 states offered both the option of a toll-free number and then also online or a chat function. Other things that we found. So over the course of the past 13 years, while paper Medicaid enrollment remains widely available, online enrollment was nearly universal as well. I should mention that because of the documentation that was required, and including state residency, that we were unable to do a review of the online platforms, just because we had to enter social security numbers and a current address for that state. And then also there was some notable improvements in the overall layout, but still much work remains. Other things is that the language availability is very, very limited, especially really the state that stuck out to us that actually offering the most diversity as far as language was by far California, offering many different languages. California also offered large print options for both Spanish and English. So they really, their Medi-Cal was really the gold standard based on our reviews early last year. So other things that, moving towards is there should be more live functions relating telephone assistance and then also live chat as well. And so California also had one of the most robust availability for, help for potential enrollees. So conclusions, our work suggests the need for states to leverage technology in creation of resources to match language and then other cultural needs of the US diverse population. So really that, as I mentioned, that many states did only offered English. We really need to be looking at related to, language spoken, related to, especially in conjunction with the newly about to be released 2020 census data. Other things need to be looked at for inclusiveness related to, large print applications as well. Our article is currently in press in special issue for health literacy in the American Journal of Health Education with Brian Fu as the lead author. One other part of the study that we looked at that's reported in the paper assesses online videos that were available. And they were relatively limited. So overall, that's something else as far as leveraging communications and technology for the future. And again, California had the best, most robust videos related to instruction for language, etc. So thank you very much.
Yep, so thank you, Lorraine, for that was a great presentation. We will now go on to any questions. I currently do not see any in the Q&A, but we did want to ask, like, what other needs after evaluating and your results did you see are needed in these specific communities?
Right, and so honestly, I really would have liked to have seen really this technology piece is very, very important. That it really that we should have, in other words, there should be examples where a potential enrollee could look, whereas, they have the application and then there's a video showing step by step how to complete that, right? And really, and far beyond English. So for states, I would suggest, looking at the most commonly spoken languages, perhaps, depending on the size of the state, but looking somewhere, between 5 and 10 languages, how can we really, bolster and make this more accessible to states? And again, to keeping this up, as part of what's reported in our manuscript that's currently in press, is that, many of the videos that we looked at were 10 years old. And so that's something that I really think needs to be, continually updated and really giving people the resources to be able to complete the application and understand, it's not that also too, the application is one piece of that puzzle, but then to also be giving people excellent resources to be able to use Medicaid.
Thank you.
Thank you.
We did have an
Thanks.
additional question, a couple of questions come through on the chat. So thank you for sending those, everyone. Brittany asked, do you see videos being most helpful for the explanation of how to complete the application, like an instructional video, or is there another purpose/use where the video might be helpful?
I think, over an overarching video, right? Maybe perhaps, I think this should be broken down really in health literacy concepts, right? So we're looking at chunking. So in other words, before you even start the application, what do you need to have in hand, right? For that particular state. And then also, breaking it down by section, perhaps short videos, looking at, this is the first page of the video that you need to be the first short video addresses the content that needs to be completed on the first page. So I think instead of, we saw one video that was like an hour and a half long, far too long. In other words, we need to have this, much more directed. What do people need to know and how do they need to do this?
Yeah, an hour-long video sounds like it might be a little long.
It was very, very long.
Yeah, thank you. So our next question is English only purposeful, do you think?
No, and this is something, that we looked at, as I mentioned, that California was really the gold standard in the number of languages that were available. We really need to be more, language inclusive. So, for states, again, this needs to be looked at related to what's commonly spoken. The technology exists, and we moving beyond Google Translate, right? As well.
Mm-hmm.
And then, do user, testing individuals, like, right, do these materials make sense? to you, right? It's just not just someone, doing even the back-to-back translation. In other words, what's a user perception of the materials and the videos, and supporting, other things that we do to support people to, to be able to access this.
Mhm. Thank you.
Thanks.
And then Dr. Mead asked, can you provide added detail on the UFT?
Yes, so the user friendliness tool was developed approximately 15 years ago by Dr. Terry Davis and colleagues. And on the slide here, so this was originally published in pediatrics. So we're looking at how, if you're assessing the material, how much work is needed to make this, health literacy friendly. So looking at, ample white space, the type of font that's used, is it active language? So I would highly encourage. So it's the article, if I can maybe, is available here. So this is an excellent article that Al knows this. So this is, it's published in Pediatrics in 2006, which I find one of the really a nice, straightforward health literacy material assessment.
Yeah, the PMAP is often used, as you well know, and there's some indexes from CDC. So it's great to know there's another one out there.
Right. And, I highly encourage those. The PMAT is great as well. I really, actually, Dr. Mead, we used the PMAT for the videos that we did for the support as well. That's cited in the paper. And the CDC index, again, is excellent as well. So there's many different resources. Actually, part and parcel, we used the user friendliness tool for this assessment so that we were able to compare to our study 13 years ago.
The key is use something for sure.
Right.
Thank you,
the
Lorraine.
PMAT is especially, I really find it especially excellent for audiovisual materials.
Thank you so much, Dr.
Well,
Wallace.
thank you so much.
Any other questions? I don't see any others in the chat, so thank you so much. If we have time for some more questions at the end, we can kind of circle back as well. But our next presenter is Aziza. Hi, Aziza. So Aziza is an entrepreneur who founded Literacy, developed a virtual-based communication platform to bridge communication gaps between low health literate patients and their providers. Aziza serves as a principal investigator in the National Science Foundation grant to develop AI-assisted product features. So she's going to tell us some more about her great work today. So you can go ahead and share your screen and get started whenever you're ready.
Thank you. Excuse me. Thank you so much for the introduction. Hello and welcome. My name is Aziza Ismail, and today I'll be presenting preliminary results from an ongoing pilot study that is being conducted in collaboration with Valleywise Health, a public safety net health system in Phoenix, Arizona, and its Refugee Women's Health Clinic. Our study focused on measuring the feasibility of a picture-based screening application for patients with low literacy. Before I go into the research, I want to start off with a personal story. In 2016, a 10-year-old relative of mine went to the emergency department with a life-threatening condition. Because of miscommunication, her symptoms were not fully understood, and she lost her life while waiting to see a doctor. Over the course of 5 years after her death, 2 other members of my family suffered from pregnancy-related complications. When they arrived at the hospital, doctors told them if they had come any later, they would have lost their lives. And in one case, the baby didn't make it. Digging into this, I learned that the core issue in their stories was a misunderstanding and an incomplete picture of their symptoms that led to misdiagnosis and delayed treatment, which then led to serious harm and hospitalization, including the loss of life. 3 incidences in one family sounds like a lot. Actually, miscommunication is a huge problem that is widespread within our healthcare system. Research from the Joint Commission tells us that nearly 80% of serious medical errors are caused by miscommunication. A Johns Hopkins study has found that upwards of 80 to 200,000 people die every year in a hospital due to poor health communication. And 56% of medical miscommunication happens when the provider is taking a history from the patient about their present condition. It is clear that good health communication between a patient and their provider is important for the patient to receive an accurate diagnosis and appropriate care, and any discrepancy can lead to patient harm. It comes at no surprise that patients with language, cultural, and low health literacy barriers are disproportionately affected by medical harm due to miscommunication twice as much. And in the United States, there are about 120 million people, or 36% of the population, who have this high risk. Now, can you imagine multiplying this number across the entire world with 7 billion people? As you already know, low health literacy is part of a larger problem that is associated with poor health seeking behaviors and poor health outcomes. And it's also a significant cost burden to the US economy as a whole. As I mentioned, much of the miscommunication occurs during the encounter with the provider. So proper health communication is a challenge for most Americans who have inadequate health literacy. And looking closely at the patient-provider encounter, we have the patients who know their symptoms and they know how their symptoms started and progressed, but they lack the medical knowledge. They may use words differently than how those words are understood and used by medical providers, and they may not know the right questions to ask or the right service to request. On the other hand, doctors have the medical knowledge, but they're limited to a brief snapshot of the symptoms based on a short remote observation and whatever the patient describes. It is clear that current patient communication with providers is slow, inefficient, and error-prone, and that increases costs and put lives at risk. Recent technological advances, such as the availability of Wi-Fi, advances in user interface design, device affordability, machine learning, and artificial intelligence have opened up a huge opportunity to augment and improve healthcare with technology. A recent report by Pew Research states that 71% of adults and 93% of teenagers in our target patient population have access to a smartphone. So it's definitely ubiquitous at this point. Literacy leverages these opportunities in the design of our interventions. So we designed a visual interface for symptom capture. The interface includes pictures, plain and simple language that helps patients describe their symptoms. It highlights any troubling symptoms and outputs a report for the medical provider to view before the patient visit so that both the patient and provider are more prepared. For this particular study, the product was designed for a more efficient and effective COVID-19 screening. Early on in the pandemic, doctors told us about the challenges with screening patients for COVID. Patients were passing the initial checkpoint, but during the visit, it was established that they did have COVID symptoms. So our interface is designed to help patients provide accurate information. So the patient accesses the web application, they click through the pictorial questions, and in this case, selecting yes or no answers. We also include questions related to medical history. When the patient submits, the medical provider receives their report. And you can see from the screenshots that we are using plain, precise English. We also currently support Spanish, Arabic, Swahili, and Burmese. We developed a study with the objective of determining whether we can improve patient-provider communication by providing low literacy refugee patients with the picture-based tool for capturing symptoms information and then relaying that information to the provider in advance of the scheduled visit. We enrolled patients who had existing appointments into our study. We sent them a link via text message and email to the online questionnaire. They completed the questionnaire within 24 or 48 hours of the visit, and then the medical provider reviewed the data prior to the encounter. The research team then compared the symptoms, inputted into the app head-to-head against the patient's medical record after completing the in-person visitation. Our results so far are promising. In 20% of patient cases, symptoms that may have been missed were identified. On average, for every 4 patients, literacy had identified 1 more symptom than the provider. The preliminary data is the result of a 30-patient study that's currently ongoing at Valleywise Health and its Refugee Women's Health Clinic with both low and non-literate patients. And the providers were aided by an interpreter and a cultural health navigator. Relating this to the story that I told you earlier, this could be the difference between life and death. Here is the distribution of symptoms. On the x-axis is each patient, and on the y-axis is the number of symptoms relative to what was recorded by the medical provider. As you can see, in 20% of cases, literacy had identified 2.7 more symptoms per patient. And in one case, as many as 5 more symptoms were identified. In 53.3% of cases, the doctor's notes matched what Literacy recorded. And this was still significant because currently most providers don't have much information on hand to prepare for a visit. In 26.7% of cases, an average of 1 less symptom per patient was identified by Literacy. We found that these symptoms were generally pain symptoms and that those are harder to elicit even within an in-person encounter. Simple changes to the interface, for example, implementing a 3D anatomical model, helped to improve some of this. And don't forget, the intent of our application is to help providers to be more prepared before they go in to see a patient. And so far, we're doing that in more than 70% of cases. In fact, providers are finding it useful. They've rated it a 4 out of 5 or higher in terms of helping them to prepare for the patient visit. We've had a few notable cases already where doctors were alerted to symptoms of a patient that could have been missed due to a communication barrier. For example, we had a case of a 60-year-old refugee woman who was not English speaking. Because she was able to use the interface prior to the encounter with her provider, she was able to identify and communicate 3 symptoms that she had that otherwise would have been missed. Another provider said that Literacy alerted her to a recent COVID infection and facilitated dialogue about recovery. And this patient was a refugee who was pregnant, and this was a telemedicine visit. Another provider said that the Literacy report was more specific than the reason for appointment, which stated abdominal pain. That was not accurate as the patient had chest pain. So that's a pretty important difference there. These are the preliminary results, and we are looking to expand from here into more health condition areas. I will wrap it up by sharing our vision. At Literacy, we believe that communication should never be a barrier to life-saving care. Our next step is to continue this work in a larger funded study and to expand this to a wider population and other medical specialties across the continuum of care. We welcome the opportunity to speak with potential partners. And so I was excited to have this opportunity to speak with you and to get to tell you a little bit about Literacy. We thank HARC for advancing their efforts in health literacy, and I'm happy to take any questions from the audience now. Thank you.
Thank you so much. That was excellent. I know I was kind of freaking out the whole time. I think it sounds so cool, everything that you all are doing. While we wait for some questions to roll in the chat, please go ahead and type those in for Aziza. I wanted to kind of get us started. So I know you talked about scaling up this as well. Do you envision that this could also be kind of tailored to different populations?
That's a great question. I do think so. My approach in the design, or at least my hypothesis, I guess, would be that by targeting populations that have the low literacy barrier, the cultural barriers, and then working with a diverse refugee population that are, some of them are Arabic speaking, some are Swahili, some are Burmese, so they come from different parts of the world, that this could be applicable to other populations as well. Hopefully that answers the question.
Absolutely. Yes, it does. Thank you. I think it's really excellent, all the stuff that, how did you kind of come up with the different pictures, or what symptoms that you were going to include there as well?
So the symptoms that we included for the COVID-19 one in particular, we work with the medical providers and medical students to develop those the specific symptoms that we'll be working with, but then we work with making sure that we kind of move away from just trying to be as plain and simple and precise about describing those symptoms as much as possible. For example, not using the term to dizzy, for example, which can be miscommunicated and misunderstood. So you have to be more precise, but then just saying that you're feeling dizzy, do you feel like the room is spinning around you, or do you feel like the room is spinning about you, for example. So that was, so as far as the content, deciding what symptoms to focus on, those came from the medical providers to know like what's important for them to know, what would they like to know about their patients before they see them. And then the other question was about the illustrations. So we did our best to try to create these illustrations in a way that could be relatable to the patient populations. And then we went through a number of different iterations until we felt like we got it correct. We run it by some of the refugee patients and ask them, like, what do you think this picture shows or what it says? And they would describe what they thought the symptom was.
Thank you. Any other questions? I don't see any in the chat quite yet for Aziza.
I think to answer also, if I can add another
Yeah,
point to
absolutely.
the first question, so we are currently also working on expanding the questionnaire into other areas. And so we do think it could be applicable, for example, to mental health screenings, you know, diabetes management, social determinant of health assessments, and intake form as well. So those are some things that we've been starting to work on. And I do think that there could be broader applicability.
Absolutely. Yeah, that's awesome. Thank you so much. Thank you.
Yes,
And if we
thank
see any other questions kind of pop up in the chat, we can try and circle back at the end. But thank you.
Thank you so much.
Thank you again, Aziza, for your time. We just did want to kind of, in case that any of the attendees are on and they're going to be discussing the critical health literacy theoretical and measurements issues, please send us a chat so we can go ahead and put you in the panelist. But for now, we are going to continue on to our next presenter, Dima. If you are having any video issues, please just feel free to unmute yourself. I'm going to introduce you very quickly though. Dima is a senior research assistant at the Department of Emergency Medicine at the American University of Beirut Medical Center. Her research interest focuses on evidence-based health management. And Dima, I see that your screen is starting to share. You can put that in presentation mode and go ahead and get started. I will send you a 5-minute reminder.
Okay, thank you for the introduction. I'm having problem with my camera. I apologize. So today I will be presenting about the relationship between news exposure and trust and belief in COVID-19 fake news and social media spreading. So as we all know, mass media has played an important role in disseminating information regarding public health, especially during pandemics. Unfortunately, people found themselves overwhelmed with news containing fake reports and misinformation, which for those without the right skills can be considered a possible threat. Therefore, misinformation surrounding COVID-19 has been considered a global public health problem that adversely affects the government's abilities to mitigate the disease and causes accidental deaths and self-harm due to false beliefs about the virus, prevention measures, death, and self-harm. Up to our knowledge, studies that have explored media and trust have primarily examined legacy media, and those that included social media preceded the universal fake news era. In addition, no study has explored the effectiveness of interpersonal communication in the context of a pandemic. As a result, we hypothesized the following. We hypothesized that trust in and exposure to social media and interpersonal communication news about COVID-19 will be positively associated with the belief in myths and false information about COVID-19. It will be negatively associated with critical verification practices before posting on social media. As well, we hypothesized that media literacy, as well as trust in information from the following sources, healthcare experts, government, will be negatively associated with the belief in COVID-19 myths and false information. On another note, it will be positively associated with critical verification practices for social media sharing, while the opposite will be true for trust in information from clerics. I just want to point out that we included clerics and religious institutions as a major source of information in our study, because in Lebanon, specifically in Lebanon, these sources play an influential role on political and social matters in Lebanon, including healthcare. The last hypothesis is that we believe that the belief in COVID-19 myths and false information will be negatively associated with critical verification practices for social media spreading. With that being said, the objectives of our studies were the following. We decided to examine the role of legacy media and social media, as well as the interpersonal communication and mitigating the infodemic. And the second objective was to examine the relationship between media exposure and trust and the belief in COVID-19 myths and false information and the critical verification practices people follow before posting on social media. So our study design was the following. We used a cross-sectional phone survey that was administered to adults who are residing in Lebanon between March 27 and April 23, 2023. We decided that phone surveys were the most feasible at the time of the study, given the need for social distancing, and because the country was undergoing strict lockdown measures to allow the healthcare sector to prepare for the pandemic. We attempted to target 1,536 participants. The response rate was 52%. So our participants' characteristics were the following: 56% of our participants were men, 44% were women, 38% completed a university degree, and 63% were older than 30, and only 7% of our participants underwent a media literacy training at some point in their life. So when we examined the association of trust in media and information sources with myths and false information, the results showed the following. Those who believe in COVID-19 myths and false information are slightly more likely to be women and much more likely to have less than a university education. In addition, trust in COVID-19 news from television, social media, interpersonal communication, and clerics was positively associated with the belief in COVID-19 myths and false information. And lastly, the exposure to television and interpersonal communication also revealed similar association. If you look at the third table, when we examine the association of trust in media information sources and the belief in myths and false information with the critical verification practices for social media spreading, the results showed the following. Those with a university education and those who have undergone media literacy training are more likely to engage in critical verification practices for social media sharing. In addition, trusting social media, interpersonal communication, medical experts, and clerics was negatively associated with critical verification practices for social media sharing. Consistently, the overall belief in COVID-19 myths and false information was negatively associated with critical verification practices for social media sharing. We did a multivariate regression analysis to adjust for the potentially confounding variables. The results of the regression showed that those who trust COVID-19 news from social media, interpersonal communication sources, and those who trust information from clerics were more likely to believe in myths and false information associated with COVID-19. Women were also slightly more likely to do so as well. University graduates and those who trust information from the government were less likely to believe in COVID-19 myths and false information. And those who believe in COVID-19 myths and false information are less likely to engage in critical verification practices before posting on social media. Most importantly, those who underwent a media literacy training at some point in their life were more likely to engage in critical verification practices before posting or sharing anything on social media. So the strength of our study, this was the first of its kind study to be conducted during a pandemic and that examined the relationship between media exposure and trust and the belief in COVID-19 myths and false information, as well as the critical verification practices before posting on social media. Up to our knowledge as well, nearly all research that was conducted on media uses and trusts during pandemic only studied the H1N1 flu pandemic that occurred in 2009, and none of these studies had happened in an Arab country. Also, prior studies mainly examined legacy media and they disregarded interpersonal communication. So what do our findings imply? Our findings imply that since our studies showed that only media literacy training predicted higher likelihood of engaging in critical verification practices before posting on social media, we emphasize the importance of media literacy training in mitigating the infodemic. In addition, we also raise a cautionary note about relying on interpersonal discussions and campaigns that exclude healthcare professionals, particularly in emerging diseases, because the knowledge about them is still evolving and changing, especially for individuals who have a low education status and for diseases that are prone to stigmatization, as is the case in COVID-19. Lastly, given that education level was negatively associated with the belief in COVID-19 myths and false information, we do believe that integrating a media literacy course in schools and university with a strong literacy module will significantly help counter the infodemic. Thank you for listening, and I'm open for any questions.
Thank you and great presentation, Dima. If any case anyone has any questions they would like to ask, please feel free to add them onto the Q&A or the chat option. Both me and Samantha will keep an eye on that. One question that we did have prepped for you is, do you have any idea about how to scale up the media literacy training to community members?
Yes, how to we mainly decided to actually, as a recommendation, to mention that media literacy should be implemented in university curricula or in school curricula, because that is not a mandatory in Lebanon. It's not even mentioned as an elective course. So we do mention or recommend that it should be part of the university, at least the university curricula.
Thank you. And Dr. Mead had a question. Might you expand more on how you assess trust?
Yes, I can. We assess trust based on several questions. They were a scale of, I don't remember the questions. I'm trying to look them up. But we did ask them to what extent they trust the following sources. And then we mentioned the sources, the healthcare professionals, the government, the clerics, what else? They were a scale of 1 to 5. So that's how we assess trust.
Thank you. Let me see if there's any more questions. And for any of the panelists, if you have any questions, please feel free to unmute yourself.
I think this was a great presentation. I think that it's really relevant right now to what we're all kind of seeing.
So at this,
go ahead, Dr. Mead.
Samantha. So at this time, our fourth presenter on critical health literacy, we don't believe she's either in the speaker or the participant gallery. If by chance you might be, please put something in the chat and we can quickly move you over. If not, we are open to any of the questions for any of the speakers. So we encourage, we still have about 54 presenters, participants on. Please put your questions in. Thank you. And we'll wait just a few moments. And I think I saw a question come in.
Yes, there's one that came through. I believe it's for Dima. Were there any specific social media platforms that were more trustworthy and less trustworthy?
We did not ask them specifically about Facebook or WhatsApp, or we just we highlighted social media as a group in general. So social media actually included Facebook, WhatsApp, Twitter, Instagram, all of the above. So we did not actually assess each one separately.
Excellent, thank you. And like Dr. Mead mentioned, we want to open it up. So if you have any questions for any of our previous presentations, any of our panelists that are here, please feel free to type those in the chat.
And I do have a question or a comment that I could ask each of our three speakers, that based upon each of your respective studies and programs of research that you shared with us today, what do you feel is your best recommendation of the next steps for health literacy? We've been exposed to lots of information at this conference. You've added some other parcels to the mix of health literacy advancements. What do you feel in your own mind is the next step and the next area that we really need to concentrate on? So perhaps Lorraine, you want to lead that off?
Thanks so much, Dr. Mead. Well, lots of food for thought here. So, I think, on the work that I've done, as I mentioned, with the two students is, I think looking far beyond English is really critical in relation. And so in our full paper that is currently in press in American Journal of Health Education, that we cited a paper study about 3 years ago where there's 350 languages spoke on a daily basis in the United States. And this is really a limitation, I see moving forward.
Thank you.
Thanks.
Aziza?
Thank you. Yeah, so I think that as far as like what focusing on for health literacy moving forward, I think there's a large opportunity to continue using new technologies to bridge the gap between patients with literacy barriers and digital literacy barriers, and between bridging that communication gap between those populations and the medical providers to make sure that they can get the right care based on how they express their health needs.
And Dima?
Based on the results of my study, I believe that it's important to actually increase awareness, especially among those who have less knowledge about social media and how to use it properly, and which sources of information they have to trust and not to trust, and and actually educate them on what are the critical practices that could be done to make sure that these sources or the information that they are reading or checking online are actually credible sources and correct information.
Thank you so much. I think we'll do our final call for questions to the group. We'll give you 10 seconds to put your burning final question in there.
10
If
seconds to
not,
type super quick, super quick.
Okay, based upon what our three presenters have just mentioned, it kind of reminds me as I think about where we've come in the area of health literacy, that especially in your work, Lorraine, materials is still a primary source of information. The way we're getting information may be changing, whether it's online, but we still need to be very attentive to how it looks, how it feels, how it can read. I think our other presenters have reinforced the need to make sure this information obviously is in language appropriate, it's also credible, and it's also trustworthy. And I think our other presenter really brought into play that digital technologies, they're here to stay, and we need to figure out how we can better reach disparate populations through this multitude of tools. So I hope this session has been helpful to all of you and has really fueled and sparked some of your thinking. So I'll let Samantha or Carol say the final word, and I think we might actually give our participants a little bit of time between now and the next session. So appreciate that. Go ahead, Samantha and Carol.
Thank you so much for that great summary, Dr. Mead. And thank you so much to our panelists. Thank you to everyone who attended. We are so glad to have spent some time with you all today. And we are very glad to give you a couple minutes back.
Have a wonderful rest of your day.
Thank you.
Okay, thanks everybody. Have a great afternoon. Bye.